We've got a hot topic. This hot topic is the HHSC payment model change for the home care providers in Texas. So this is for a Texas provider attendant services payment model change that just happened back on September 1st, 2025. There are a lot of changes. The cost reporting fiscal year has changed. The due dates remain the same, but there's large implication because of the fiscal year end changing as to the due date. Cost reporting rules are changing. Cost reporting system is changing. I do not have all the answers, but I'll share what I do have. TAC has pulled me in along with one of their other consultants to help communicate all these changes with the providers. My role is to educate the providers. Further on that topic is I want you guys to always see me as in the provider's corner. And I can at least on the financial and cost reporting side, translate the changes and what's going on. So that's my role. Okay, so what's changed?
Welcome back to the Home Care Experience with T&A, hosted by Amy Taylor and Troy Brooks. With the September 1st shift to the brand new HHSC payment model, everything from your reimbursement rate to your wage structure has changed. Amy Taylor is stepping in solo for this special breakdown episode to walk you through what the state actually requires, what misinformation is circulating, and how to prepare your agency before the next cost reporting cycle sneaks up on you. From avoiding the upcoming naughty list to understanding the real math behind the 90% spend requirement, Amy is here to translate policy into plain English and help you protect your agency.
Hey everybody, it is Amy Taylor. I don't have Troy Brooks here with me today, but he will be back very soon. I just wanted to get on and record because we've got a hot topic. This hot topic is the HHSC payment model change for the home care providers in Texas. So this is Texas specific. So if you're not a Texas provider, this won't have any value unless maybe you're looking at moving into Texas. So this is for Texas provider attendant services payment model change that just happened back on September 1st, 2025. So most of you all know that we've gone to a new payment model. The state has gotten rid of ACERS, which is the Attendant Compensation Rate Enhancement Program. And in the nursing facility world, we call it the staffing enhancement. All of that is gone. That is where you were getting paid. You had to enroll, and there were different levels of participation from 0 being non-participant all the way up to level 35 as the highest participant level. And each level, you got 5 cents per hour of service additional reimbursement, but it also came with some rules where you had to spend 90% of a certain cost component. It had to be spent directly on attendant compensation. We've got a new model. That goes totally away. I'm not going to go into the history of it or legislation, but basically it was very difficult for the legislators to understand ACERS and therefore make it fair and equitable. So they just scrapped it. And I think this is going to be good for all providers, because what they had to do was make sure that nobody, it's called a hold harmless. Nobody got harmed by this law change or rule change. That meant they had to act as if everybody was at level 35 and the reimbursement had to stay there or higher. I want you to hear that, because a lot of the focus on this new payment model has been about how you have to spend the money. Let's first talk about the fact that your reimbursement rate is now even. Everybody has the same reimbursement rate, and it's higher than what you've been paid in the past. So effective 9/1/25, your reimbursement rate for PHC non-priority is $17.13. So $17.13 per hour, per unit of service. I can't quote all the others, but they also changed. This goes for everybody, but PHC non-priority is the most prevalent program, so it's the easiest one to talk about. Start with that in mind. You're getting paid a higher rate now. What are the rules around this higher rate? That's what I kind of want to talk about. There are a lot of changes. The cost reporting fiscal year has changed. The due dates remain the same, but there's large implication because of the fiscal year end changing as to the due date. Cost reporting rules are changing. Cost reporting system is changing. I do not have all the answers, but I'll share what I do have. And I've been on the leading edge of staying informed on this since it came out. TAC has pulled me in along with one of their other consultants to help communicate all these changes with the providers. The other consultant is kind of the go-between between HHS, really the lawmakers, HHSC, and the association. And then I take it from the association and from what she's boiled it down to the provider. My role is to educate the providers. And further on that topic is I want you guys to always see me as in the provider's corner. Okay. So I'm in the provider's corner. While I don't do provider operations, and there's a lot that you guys do that I don't even know or understand, I'm in your corner. And I can at least on the financial and cost reporting side, translate the changes and what's going on. So that's my role. So I talk about me as being one of you. So I'm in this with you somehow. Okay. So what's changed? Let's talk about the payment model change. So you're getting paid at a higher rate. Everybody's on the same playing field. The biggest thing that's been discussed thus far is the new average wage requirement. I stress that because it's an average. It is not a minimum. And we need to make sure everybody is hearing this. We're already hearing stories of providers that acted too quickly without all the information that's come out since. And now we're going to have to try to go backwards in a move that's going to be difficult, if not impossible. I'll explain. Prior to 9/1, you had a minimum wage requirement of $10.60, right? That's gone. You are no longer, the only required minimum wage is the federal minimum wage of $7.25. That's the only requirement. The way this new legislation came out, you've got to think about it from a lawmaker's perspective or somebody like way up at a 80,000 foot, they're out on the satellites looking down. They're not down in the weeds of doing this work. And they have statistics, like they know in total how many hours of services are delivered. They figure out, okay, what we're trying to do is we think attendance fully loaded. Well, I shouldn't say it that way. We think attendance should on average earn $13 an hour. So that's what they appropriated for reimbursement into the Medicaid home care program. They said, okay, we do, a billion hours of service, $13 an hour. Here's the number. Don't make me do that kind of math in my head. So that's where they came up with. So you do have to have a little bit of history there. That's the amount I'm going to give you on where this $13 came from, because what providers heard and what they were told by many you got your caseworkers, case managers, but your case managers from the MCOs and from HHSC, those contract monitors, that's the word I was looking for. The contract monitors were out there saying it's a minimum of $13, and providers were hearing a minimum of $13. That is wrong. That's incorrect, misinformation. I don't even like that damn word, but it is. It's just wrong. It was not understood right. And so some providers went out and said, oh, I got to raise my hourly wage, my minimum hourly wage to $13 an hour. And they did that bad. That was a bad decision. The idea is that you average $13 an hour. So one of the biggest changes is that they came out with this average hourly wage. They want providers spending an average hourly wage of $13 an hour for attendance. They want the attendants to, on average, across the entire state on average earn $13 an hour. And so that was just hey, we think attendant services, somebody that's providing that kind of care, should average about $13, meaning maybe when you start off, you're starting out at $10 or $11, and maybe after you've been there 3, 4, 5, 10 years, you're making $14, $15, $18 an hour. But on average, the average wage is $13 an hour. They then added 14% to cover payroll, taxes, and benefit. They refer to that as PTB. So $13 plus 14% of $13 is $14.82. Then the rule requires, similar to ACERS, that 90% of that $14.82, that's the the attendant cost area of your reimbursement rate. Remember, we already said your reimbursement rate is $17.13. The attendant cost area, the attendant portion of that, is this $14.82. That's the $13 average wage plus the 14% to cover payroll, taxes, and benefits. So that gets you to $14.82. Then the other piece of that is $2. It used to be $207. It's $231. That makes up your $17.13. So the $231 is your support service piece of it, right? So you got area attendant cost component, service support component. That makes up your entire reimbursement rate. So let's just focus on the attendant cost area. You are required to, not required, you're required. You're required to spend 90% on attendance, just like under ACERS. The big difference, ACERS attendant compensation rate enhancement. So under rate enhancement, the difference, there will be no recoupment. If you do not spend 90% on attendance, then you're not going to face a recoupment. However, you will be listed on a list that goes to Congress. Congress is requiring that any provider that does not meet that 90% spending is listed on a list that has your name, your provider number, and it will be public. So we are going to call that the naughty list. Although, I've really changed my tone over the last 3 or 4 months about this. And the reason is, at first I was like, that's the naughty list. I don't want to be on it. I still don't. But what they're doing is they're going to take this list and see what it looks like. What if, 75% of the agencies fail to meet that spending requirement? Does that send a message to Congress to say this is unreasonable? Now, I would highly caution against that if you've got a big profit. So you're going to want to measure that, right? Are you meeting your spending requirement? You're not going to have a recoupment. But if you've got a big profit and you don't meet the spending requirement, that may not be a good formula. I think you should be able to meet it. I've done some assessments of my clients. You're being allotted 14% for taxes and benefits. I've yet to find anybody whose taxes and benefits add up to 14%. I've been finding more around 12%. I've run some numbers, and based on let me see what this tax rate is. Based on a tax rate of, this one's only 8.75%. If your tax rate is as low as 8.75% between FICA, FUTA, SUTA, and benefits, your average wage will need to be $12.26. Did you hear that? That's a low tax rate, and your wage needs to be $12.26. If your tax rate is even higher, your wage can go lower. It's an inverse relationship. So this is why when some providers ran out and started paying $13 an hour and across the board, and then I'm assuming you're going to have to give raises to people at some point to keep up with inflation and to keep them employed and not going to another agency, you're going to be eating into your service support component to cover your wages. So they only make you spend 90% on direct care cost. They're leaving you what we call 10% as a holdback. That can either go to cover admin, to cover additional compensation for attendance, or to cover profits. But those are the elements that you want to balance. So I see 3 elements: 90% to your attendance, you got your service support component, and you got your 10% holdback. And those are what you've got to balance between to keep everything straight. I feel agencies should do well under this payment model. It's going to make you guys all on the same playing field. Think about an agency that was only enrolled at level 7, couldn't get any higher, kept asking for it. You can't go up unless there's appropriations for it. So unless there's enough money in the budget and some of your 35 level people drop out, it just wasn't fair. So you're at level 7, somebody else is at level 35, 28 times 0.5. They're getting paid $1.40 more per hour than the agency at level 7. How is that fair? So if you were on a low level, you could lose attendance easily to the other agencies that could pay more. This levels the playing field. The reason it's set up as an average wage is because they want to let you, and I loved it because they actually said this on the panel when I was at the annual meeting for TAC. I was on a panel with HHSC, and they said they've done this so you can run your business how you want to run your business. And I was like, yes. So think about this. Think about being a big agency, and you got operations in DFW, but you also got operations way out in West Texas. You might be able to get away with paying $11 and $12 in West Texas, but in Dallas, you got to pay $14, $15 an hour. The idea is that you can do that. And as a whole organization, your average is $13 an hour. That is what they're trying to get to. Or think about it a different way. Maybe you're not a big agency spread out, or maybe you're big, but you're just in one area. But you're in one area, same cost of living for everybody. Maybe you start attendance at $10 an hour. Year 1, you get $1 raise, you're at $11 an hour. Year 2, maybe after year 5, you're at $15 an hour, or year 10, whatever it is. You could really stratify your wages. Maybe it's not even tenure, but maybe it's performance-based. You can set up, I love performance-based pay. We call that incentive pay. I love it. It can drive, if people are money hungry, they will work for it. And so you can do that, right? So maybe you say, hey, I'm trying to make something up. If you can get 10 clients to give us Google reviews, I'll give you a quarter raise or something, right? Like you can have little incentives, little contests. Maybe it's just little bonuses. We do that. So, anyways, so that's what it's designed for. Now, let me get into what is going into this cost component, the attendant cost component. It's very similar in the past. Anything that's a taxable wage is considered wages. And then FICA, FUTA, SUTA, health, which is vision, medical, dental, any insurance benefit that the company pays for. If the company paid for cancer and supplemental insurance and life insurance, that all counts. But it has to be directly for attendance. And then what it does not include, which is a big change, is mileage. Mileage is no longer included. They're doing that because in the Medicare access rule, so CMS has a new rule coming. It's a few years out still, where 80% has to go to attendance, blah, blah, blah. And that rule, mileage is not included. So they're just trying to align the state programs to better reflect the CMS requirements that are coming down the road. And so mileage is not recorded. So let's talk about that for a second. If you currently pay mileage and you're like, oh, this is not going to be good, let's talk about it. You can still pay it. It just doesn't go into that 90%. It goes into the service support component. If you already pay it, and that's going to be a big, big problem, could you pay it as a taxable wage? It could still say mileage. So I'm very intimately, I know payroll well. It would be a pay item. You could even still do 40 cents or 50 cents per unit, 625 units. Here's the mileage pay. But it just would have to be taxable. Okay. So they still get it. It's still a deduction for you, but being taxable, now it's in your 90%. You could do trip fee. Maybe you only pay it for the ones that have to go way out of your, on the outskirts of your geographical service area. You could do trip charges. You could do a daily rate, different things like that. But any of it would need to be taxable. If you're not paying mileage, don't start now. Also, I want to caution you, this is another area where I've really kind of turned around my thinking. And what I mean is, at first, I came out hot. I was like, well, just make it a taxable wage. Well, I've cooled my jets. Think about this. I kind of mentioned this early on, I think. If everybody, not everybody, but let's say I like it if you're paying mileage, it's going to have a separate place on the cost report. I think for the industry, it is better that it's not as a taxable wage and you show it as mileage and you keep paying it and it comes out of your service support component. The reason being, if everybody does that, you're going to be able to show Congress mileage is a problem. It's something we have to pay. You took it out of the attendant cost component and you put it in the service component. So we're still not covering our overhead. And it's because of mileage. And either they say that they won't put mileage back in the attendant cost, but maybe they'll up that service component rate. So I say that it's better for the industry, maybe not better for you individually, because it doesn't count in your 90%, but better for the industry, because if the industry as a whole can show we're struggling because we do have to pay mileage to some of these people and it's no longer covered and we got to pay it out of our admin. There's not enough in admin support to cover admin and mileage, if that makes sense. So everybody's going to have to make their own decision on that, on how they handle it. But that's the biggie. The other big one is training expenses. Training time counts in your 90%. But if you pay for a webinar for your attendant to take, that is no longer, the cost of the webinar is no longer an attendant cost area expense. If you pay for a CPR class for them, that doesn't count. That's not a direct attendant cost. All of that has to come out of your admin support. Training time does count. The other thing is there is a big FAQ, and I was reading up on it. I need to see it in the cost report, but they're saying that the supervisors, cost related to field or clinical supervisors, will also be included as attendant care expenses. So that's a good thing. But I need to see more definition on that. I need to see more specifics. I was thinking it was going to be, when the supervisor is with the attendant at a visit, but I'm not sure that that's the case. I'm not sure that's the case. So on to the cost reporting. We're going to have a whole new cost reporting system. It's going to be called STEPS. I highlighted it. State of Texas Electronic Provider System. We don't know what it looks like yet. We won't know until January. It is in effect for these next coming cost reports that we file. I need to go through some dates, but before I do that, there is a training. It's not even a training, it's a webinar about this new system on 12/10, on December 10th. I registered for it already. It is on the Provider Finance Department website, formerly known as Rate Analysis. And I happened to land there and I saw it, clicked on it, so I got registered for it. I did read the updates for that STEPS system. It's not really giving me anything definitive other than dates, but it does talk about how important it is because all the registration email and cost report due info, all that info is going to go to the email address on file in your PIMS system. That is Provider Enrollment Management System, PEMS. That's going to be with State of Texas. So what it says is to make sure you log in there and make sure your entity contact and financial contact are correct. So if somebody's left, if you've got a new administrator, if you've updated emails, whatever the case may be, you're going to want to log into that system, get that updated. Let me see if it tells me when. It doesn't say when those emails are going to go out. So you're going to want to just get that updated just so that when those emails go out, you're in the know. It's going to be important. So that's the system. The one thing I did ask when I was in annual meeting, so that would have been the very beginning of September, I said, well, we don't even know what data to gather, what the information is going to look like that's requested. Is it similar to STARS? And they said, yes, it's definitely similar to STARS. We're just trying to make it more user-friendly. And the key thing they said, which at first I was excited about, then I was like, well, I'm not sure if that's going to be good or not, but we'll see. Their mission is to pre-populate the units of service area of the cost report. I was like, sweet, that'd be awesome. And it will be. But I know for me, that means we're going to be getting into the cost report system early and getting to that step that shows the units of service. So I can take that data and show it to the provider and say, hey, here's what the state shows. Here's what you show. We got to get that to match. Because, in the past, we report what the provider has, and then the state comes back and says, well, that doesn't match state records. Please explain the difference. Well, tell me what the state shows. I mean, it's just annoying. So I think it's a good thing, but I am concerned about how accurate is it going to be. We'll see. We'll see. So I'm excited about that. So I'm expecting it to be very similar. I think we should still be gathering and compiling the same data, but I'll know more hopefully in December, just a couple of weeks away for that seminar or webinar. Then let's talk about dates, but I definitely got to flip back in my notepad. Okay, because this was just at the administrators conference last week or a couple of weeks ago in Houston. And again, we were on a panel with HHSC, and she was very specific on dates because this is what we've been waiting on. Let me go dates. Okay. In this legislation, it changes all providers must now report on a state fiscal year. The state fiscal year is 9/1 to 8/31. That means most of my providers all operate on a 12/31 year end. Maybe some old agencies might have a different year end. All of that goes away. Everybody will be required to report on an 8/31 fiscal year end. I have a nugget that I need you all to hear, but I want to get through these dates. So the big question has been, what are we going to report on this coming spring 2026? So the first cost report we're going to do, and we're only doing cost reports every other year. So this first year, home care will file cost reports in 26. They will be due April 30th, 2026, and it will be for the reporting period of 9/1/24 to 8/31/25. Very, very few home care agencies did any reporting for 2024. So now this is going to pick up from 9/1/24 to 8/31/25. So that year is already closed out, but there's no recoupment. There's no spending requirement. You were under ACERS. It's just going to be a regular cost report with no recoupment possible. The next year, 2027, we don't file anything. The next year, 2028 filing season. So April 30th, 2028, we're going to be filing cost reports for home care for 9/1/26 to 8/31/27. So hear me. We have a year of practice, a year and a half, really a year, whatever, of practice. We got a lot of time to get ready. The cost reports that we will file will not be until April 30th of 2028 that have this new 90% spending requirement. So when I say practice, you've got time to get that figured out. And I encourage every provider, especially in this first year, to really start doing like a quarterly, I would say quarterly at minimum, quarterly rate review, spending review. Look, interim rate review is a term that's the OGs will remember from IPS days in the late 90s, the late 1900s, as the young people like to say. Anyways, spending review, a periodic spending review. You could do it monthly. You could do it every pay period. What you want to do those reviews is ideally you want a payroll system set up that gives you everything you need in one report. And it's possible. And that's what you've got time to get dialed in. So again, that reporting year doesn't start until September 1st of next year. So you've got from now until September 1st of next year to really dial in your systems, because 9/1/26 is when the data collection is going to start and it's going to matter. The reason I say that is because cost reporting, we've got to collect the data all year round. I said that wrong. Payroll systems. You know, you want a good payroll system in place, because if you're in the middle of a reporting year and you've got data in one place and data in another, it's got to be merged together. It's just messy. My recommendation is to really, really focus on dialing in your payroll system by September 1st of 26. What do you need? You need a payroll system that has your attendance segregated. I'm going to tell you right up front, Gusto is not it. QuickBooks Online is not it. QuickBooks Desktop is not it. If you want easy, good, clean data to report with, those are not your systems. You need a big, robust system. I am not an ADP fan, but everybody knows the name. You want an ADP style system that can deliver the data. But again, garbage in, garbage out. You've got to make sure you get it set up right. I will plug my firm Works, WHIRKS. Works can handle it. They know how to set it up. We're working closely with them. We will probably develop custom reports to be spit out on demand that we can pull at any time and review this. But if you're with somebody else, Paylocity, Paychecks, ADP, anybody with a good reporting system can handle this reporting. What you want is you need your attendance in a separate department, and you need a report that will show employer taxes for the department. You want it summarized by department. So you want department totals. And not only taxes, but if you offer benefits, those payroll systems, you can set it up let's say you do offer benefits and you pay 100% of the employee's premium. Let's say realistically, you pay 50% of the employee premium. And so in general, when you don't care about tracking this data, what you do is you just say, well, we're going to deduct your portion out of your paycheck. That's all we ever see in payroll is what the employee paid. That doesn't count. What we need is what did the employer pay for the attendant. In the payroll systems, you can set that all up. You can say, here's the employee deduction, and here's my employer cost for that employee. It's called a memo calculation in most systems, but it will, if you set it up, it will then print out on your reports. That is ideal. Your workers' comp tied into all of that should then show the workers' comp attributable to attendance. You've got it covered. If you've got all of that, then everything you have is in one payroll report. All you got to do, you could do it every single payroll. Maybe, I'm just brainstorming, maybe, I set up a report that actually shows, I don't know why it couldn't take, attendant wages plus FICA, FUTA, SUTA, employer health, employer, workers' comp, total, divided by total hours. That's your average spend right there. You will know what the 90% is the exact same number for everybody, and it's $13.34 is your required spend per hour. That could be in a payroll report right there. Bam, right? So get that stuff dialed in by 9/1 and you'll be off and running 9/1 of 26. Now, here's another problem about this shift with the state fiscal year. That shift is if you're, wanting to do bonuses to meet your 90%, I highly recommend it. Do your wage increases slowly and deliberately. And I want to remember to come back to my story and then use bonuses to supplement. It's going to work out great on the timing, but you've got to change your timing. In the past, your fiscal year ended on 12/31. The rules for accruals, so any kind of accrued expense, you've got 6 months to pay it out for it to be included on that cost report for that year. So that gave you until June 30th. Cool. We did your cost report in March and April. So in March, we're calculating your cost report. We do your reviews of your spending, and we say, hey, you're underspent by $50,000. We need to accrue bonus and tax, wages and taxes of $50,000, and you've got until June 30th to pay it out. Well, that sounds fine and dandy, but now that timeline has changed. The cost report's still due in April. I'm still going to be doing cost reports in March and April. But that fiscal year end of 8/31 means you've got to pay any accruals by February. Let's just call it end of February, February 28th. I haven't even reviewed spending at that point, unless I'm being very proactive, but me as a cost report preparer, I haven't reviewed it. I'm advising everybody. And then internally, my firm, we're going to start cost reporting in November, December, probably November, maybe October, November. But November, we're going to do that review, that spending review, because then we can advise how much you need in bonuses. And you've got November and December and January, February to get them paid out. But I will be advising all my clients, spend that money in November and December, use it for Christmas bonuses. It'll hit this year's tax expenses and the cost report, and you'll meet your spending requirement that way. So that's the big shift, even though they're still due in April. Okay. So we're going to have to add an additional layer of service so that we go in and review it in November and make sure you know what you need to spend before February. So when we go to report it in March and April, it's good to go. My story, it's just a little one. In the last live conference that we were at, there was a provider and she was worried because she acted too quickly and she increased everybody to $13 because she heard the misinformation of you've got to increase everybody. 13 is a new minimum. It's not. And those contract monitors that are saying that, they're wrong. HHSC has been informed, but if you've got a contract monitor, get their name, report it to TAC's reporting it to HHSC. If you're not a TAC member, shame on you, you should be, but you'll have to report it to HHSC directly. They're trying to get better education out. I will also add this little caveat. On the last panel, I made the comment. I said, when you take this back to HHSC, can you also ask them, start training their field staff to adjust their tone? Okay, let me say that in Amy Taylor terms. They need to settle the F down and quit treating every provider like they're a criminal until they're proven that they've been doing something wrong. Because in this world, if you recall at the beginning, I said there's a consultant that works between Congress and TAC to help the policymakers. She's more of a policymaker. She's able to take what providers need and translate it to Congress. And she made the comment, it was just me, her, and Rachel from TAC on a call. She goes, well, provider finance, HHSC, they're not the bad guys. They're not bad guys. They're not bad guys. I was like, well, you ain't in the field. You see how they treat the providers. And I've been there. I've been through audits with you guys. They don't treat you respectfully, and they treat you, I shouldn't say they as in all of them, but I know you guys are feeling me. You know that a lot of times you're treated guilty until proven innocent, right? That's all I'm saying. So I did send that message, they could really adjust their tone. Back to my story. So this provider, she's worried, she's upset because she adjusted everybody to 13. And she's like, I'm afraid that's not sustainable. And I'm like, it's not. I heard providers talking about 15 an hour. It is not sustainable. It's not. They will go out of business. So be smart with these adjustments that you make. Go slow. Measure. Calculate what you think you got to kind of back into it. You got to go figure your tax rates. Be careful. Don't use your SUTA tax rate as 2.7 across all wages. That's not going to get you there. You only pay SUTA on the first $11,000 of each attendant's wages. So that's not truly your tax rate. It is, but only on $11,000. So, think about it. If you've got somebody that works for you and they made $22,000, then that effective tax rate's only 1.35. That's half, right? So you got to figure out what are your effective tax rates? What are you physically paying for attendance? And kind of back into what your average wage should be. What I've been calculating has been coming in between about $12.25 and about $12.75. Depending on how much you offer in benefits. Let me look at this PDF, this FAQ. There is a decent 13-page FAQ that they put out. It's on the Provider Finance Department website. All of this is also on TAC's website. This is Information Letter 2025-25. And I think I've gotten through it all. It's a lot of detailed minutia to get through. I will be attending that webinar in December and put out more information. I know that with TAC, we're already talking about education and cost report training in the February annual meeting, which I think is in Fort Worth. I think Fort Worth is misleading. I think it's actually at the racetrack north of Fort Worth. I remember last time they did it there, I was all excited about being by the stockyards. We were nowhere near the stockyards. We were at the racetrack. So it's way out there. But don't quote me on that, but I think that's where it is. Anyways, so we will, and then I know I will probably do some kind of cost reporting webinar of some sort to screen share and show how to and things like that. So hopefully it's not a huge change. I'm not ready for a big change personally, but all right, guys, that's a lot to digest. Let us know if you've got any questions, and we're here for you. All right. Thanks, everybody. Thanks so much for joining us on the Home Care Experience with TNA. We hope you enjoyed today's conversation and found it insightful. You can find more episodes of the Home Care Experience wherever you listen to your favorite podcasts. We'd love it if you could share this podcast with your network and/or leave us a review. It really helps us reach more people who are passionate about home care and hospice. Visit thehomecareexperience.com for links and resources in the show notes. Until next time, take care and keep making a difference in the lives of those you serve.